minutes of the session. You need to describe hypertension, the latest description of hypertension. You need to classify it. You need to explain the rules of halves. What is the rule of halves in hypertension? And discuss the prevention of hypertension. We'll go to ischemic heart disease later on. So to start off with, hypertension is basically a chronic condition of concern due to its role in the causation of coronary heart disease, stroke, and other vascular complications. And it's the most common cardiovascular disorder that poses a major public health challenge to populations in socio-economic and epidemiological transition. Now, what do we mean by transition? It means a change. Okay? So we are in a transition phase. We had communicable diseases earlier, then we shifted to non-communicable diseases, in which cardiovascular diseases are the largest ones. They have the largest share. It's one of the major risk factors for cardiovascular mortality, accounting for 20 to 50% of all deaths. All the statistics have been taken from the recent WHO website. So it leads to organ damage, according to your textbook, Park, and the extent of organ damage often correlates with the level of blood pressure. But this is not always the case, because the rate of progression that the organ has been damaged varies from one individual to another, depending upon many influences. Blood pressure and organ impairment should be evaluated separately, or often we mix both of them together, but they should be evaluated separately, since marked high blood pressures could be seen in some person and there would be no organ damage, and vice versa, that low blood pressures would lead to high organ damage. The presence of signs of organ damage confers an increased cardiovascular risk to any level of blood pressure. So this was an earlier classification in which normal, you had these categories of systolic and diastolic blood pressure. So normal was considered to be less than 120 systolic and less than 80 for diastolic blood pressure, 80 millimeter mercury. Pre-hypertension was considered as 120 to 139 systolic, or diastolic as 80 to 90 millimeter mercury. Hypertension was considered having two stages. Stage 1 had a blood pressure of 140 to 159 or 90 to 99 diastolic. And stage 2 was considered to be more than or equal to 160 systolic, or more than or equal to 100 millimeter mercury for diastolic blood pressure. I hope you all are writing your names. Okay, great. So if we classify hypertension, it's divided into two categories, basically primary or essential hypertension and secondary. So essential hypertension, when the causes of hypertension are generally unknown, we don't know. Okay? It's the most prevalent form of hypertension that accounts for around 90% of all the cases of hypertension, when the cause of hypertension is not known. Okay? Then you have secondary hypertension, when there is some other associated cause. So prominent among these diseases are kidney diseases. You already know that. Chronic glomerulonephritis and chronic pyelonephritis are the examples. Tumors of the adrenal glands, congenital narrowing of the aorta, or toxemias of pregnancy. Altogether, these are estimated to account for only 10% or less of the cases of hypertension. So most of the share is of essential hypertension when you don't know the exact cause. So this is a recent classification of American Heart Association. Okay? It's of 2017 and it's still working now. And according to this classification, we have the categories of normal blood pressure, elevated, hypertension stage 1 and stage 2 again. So systolic blood pressure, when you have a normal BP, it is considered to be less than 120 millimeter mercury, and the diastolic blood pressure of less than 80 millimeter mercury. So the treatment and follow-up, you'll be going through it in different sessions. I'll not be focusing on it. My focus will be on the classification right now. An elevated blood pressure would be considered to be having a systolic blood pressure of 120 to 129 millimeter mercury, and less than 80 millimeter mercury. Hypertension stage 1 involves a systolic blood pressure of 130 to 139 millimeter mercury, or a diastolic blood pressure of 80 to 89 millimeter mercury. Yes, someone raised their hands. Okay. I'll take all the questions. Yes, okay. I'll take all the questions at the end of the session. Okay. Now, one thing to understand here is very important, that for normal blood pressure, you need to have a systolic and diastolic blood pressure of less than 120 millimeter mercury and less than 80 millimeter mercury. But for hypertension, either systolic or diastolic blood pressure should have these ranges. So this is something important. And then stage 2 will be where the organ damage actually occurs. That's having a systolic blood pressure of more than or equal to 140 millimeter mercury, or more than or equal to 90 millimeter mercury of diastolic blood pressure. Either one of them is okay, is considered as stage 2 hypertension. So these guidelines, what do they stress upon? They stress upon the importance of using appropriate techniques to measure your blood pressure. Okay? And recommend the use of home monitoring of blood pressure instead of coming to centers to get your blood pressure regularly checked. And your instruments need to be validated, and they highlight the importance of appropriate training of healthcare providers once they have these conditions of blood pressures. So what are the other changes that included before these classifications were introduced? Only prescribing medication for stage 1 hypertension if a patient has already had a cardiovascular event like a heart attack or a stroke, or is at high risk of heart attack or stroke based on his age, the presence of diabetes, chronic kidney disease, or calculation of atherosclerotic risk using the same risk calculation used in evaluating high cholesterol. So only you need to prescribe medication for stage 1 only if these conditions are there. If they're not, if any one of these conditions is not present in the patient, you will not prescribe medication for stage 1 hypertension. So you need to recognize that many people will need 2 or more types of medications to control their blood pressures, and that people may take their pills more consistently if multiple medications are combined into one single pill. So it's easier for people to comply with. And you need to identify the socio-economic status and psychosocial stresses as risk factors for high blood pressure that should be considered in a patient's plan of care. So it's a multi-pronged approach. It's not only the clinician who deals with it. It's for example, if there's a clinician, there could be a psychiatrist also to identify any psychosocial risk. There could be a person dealing with socio-economic economics of the patient and understanding what could be the causative agent. There might not be any secondary cause. There might be that might be evident. For example, kidney problems. There may be some underlying cause that might not be seen by the clinician. So in case if there's a psychosocial stress, for example, that person might need some medication to remove that stress as well. Now coming towards the rule of halves. How do we know what is the magnitude of the problem in any community? This is not only for hypertension, it could be for any other disease as well. So we have different shapes of circles here. This magnitude of problem can be seen through the rule of halves. So the huge circle that we see here, the largest circle, is for the whole community. This outer border is for the whole community. Then within this community, there are certain people that are denoted by this red portion in the circle that are normotensive. Okay, they're not too many, because then you have this inner circle, there are people who are hypertensive. And amongst those hypertensive people, there's a huge chunk of people who are undiagnosed, who have hypertension, but they are not diagnosed. Then there are certain people who are diagnosed, showing this border, this blue border, and within this blue border you have this blue circle. This is denoting people who are diagnosed but they are not treated. Now this inner circle, this boundary, inner boundary shows this is denoting the people who are diagnosed and treated, a very small number of people. Then there is a huge number of people who are diagnosed and they are treated, but they're not adequately treated. This is a huge number. And there's a small, this yellow circle that shows that only these people are adequately treated amongst all those people who are. So this rule of halves, why was this introduced? This was introduced because hypertension is known as an iceberg of disease. Now, what is an iceberg of disease? You have a tip of the iceberg, which we can see actually, but the actual share of all the people who have hypertension are in the community who we do not see, who do not come to seek help. So we only see those who seek help. That's the tip of the iceberg. We do not see the submerged, the large submerged portion. So this rule of halves tells us who are those people who are in need of these intensive care. Only about half of the hypertensive subjects in the general population of most developed countries were aware of the condition. Only about half of those aware of the problem were being treated, and only about half of those who were treated were considered adequately treated. If this was the situation in countries with highly developed medical services, in the developing countries, the proportion would be not too far less. Then there's a terminology called tracking blood pressure. Now, you're tracking blood pressure from the early ages to adulthood. This phenomenon of persistence of rank order of blood pressure, this is the persistence. So if you start off with high pressures, you're likely to carry on in your adult age with the same pressures or raised pressures. This knowledge can be applied in identifying children and adolescents at risk. So you might not be able to intervene for everyone, you might not be able to treat everyone, but when you're tracking a blood pressure of someone who from the young ages, and you will have an idea that this person would be at risk of developing hypertension at a future date. So if blood pressures levels of individuals were followed up over a period of years from early childhood into adult life, then those individuals whose pressures were initially high in the distribution would probably continue in the same track as older adults. In other words, low blood pressures, you'll have a lower blood pressure in the older age. High blood pressures, the same goes for them. This is a graph showing on the x-axis you have the time and blood pressures at the y-axis. So people who had lower blood pressures earlier in age would have lower blood pressures at older ages as well. And the same goes for people who had higher blood pressures, for example. So with age, with time, they'll have higher blood pressures in the coming years as well. Now coming towards the risk factors of hypertension. So for prevention, you must know what are the modifiable and non-modifiable risk factors. You have age. So with increasing age, you have higher blood pressures. You have sex, gender. Early in life, there was little evidence of a difference in blood pressure sexes. So adolescents, men display a higher level, average level of blood pressure compared to females. Okay, so in in women and men, there's little evidence of a difference. In older ages, men have a higher blood pressure. This difference is most evident in young and middle-aged adults. And later in life, women are at increased risk. So that the reason may be post-menopausal changes that contribute to this change. And then there are genetic factors. Some people are born with it because they have these factors in their genes, and ethnicity. So higher blood pressure levels were found in Black communities compared to other ethnic groups. Now you have certain modifiable risk factors that you can modify. So it's obesity, it's salt intake, it's saturated fat, it's dietary fiber, you have alcohol, you have a heart rate. So higher heart rate could lead to hypertension due to resetting of sympathetic activity at a higher level. You have physical inactivity or physical activity, you have environmental stresses, and you have socioeconomic status. Now coming towards the prevention of hypertension. So you have the two categories basically. We'll not talk about tertiary prevention. We only will deal with primary and secondary prevention here. So in primary prevention, you have two strategies. You have the population strategy that caters to the entire population. And then you have the high risk strategy that is only for those people who are at high risk of developing high blood pressures. So the population strategy is directed towards the whole population, irrespective of the individual risk factors. So the concept is that even when you reduce the blood pressure to a very small level, like only 2 millimeter mercury reduction in the entire population would lead to marked reduction in the incidence of cardiovascular complications like stroke and CHD. So your goal is to shift the community distribution of blood pressure towards lower levels or biological normality. So you make this a biological phenomenon that everyone would have lower blood pressures in the community. This involves multiple factors and multifactorial approach based on the following non-pharmaceutical interventions. So you have lifestyle modification to manage hypertension. This has been taken from your textbook. So weight reduction, there should be a maintenance of normal body weight. Okay? And the recommendation is a BMI of 18.5 to 24.9. Adopt DASH eating plan. So this is dietary approaches to stop hypertension, in which you consume a diet rich in fruits, vegetables, low fat dairy products with a reduced content of saturated fat and total fat. And then dietary sodium should be reduced to no more than 100 milliequivalents per deciliter. That means 2.4 grams sodium or 6 grams sodium chloride, not more than that. Physical activity, you need to engage in regular aerobic physical activity such as brisk walking at least 30 minutes per day, most days of the week, and moderate consumption of alcohol. So what's the secondary prevention? Its goal is to detect and control blood pressure in affected population, affected individuals. Modern antihypertensive drug therapy can be effective to reduce the high blood pressures and consequently the excess risk of morbidity and mortality from coronary, cerebrovascular, and kidney diseases. So the concept comprises of early detection. You detect earlier and then you intervene earlier as well. So early detection it's a major problem because high blood pressure rarely causes symptoms until there's organ damage, which has already occurred, and our aim should be to control it before this happens. And the only effective method of diagnosis of hypertension is to screen the population. So through blood pressure monitoring. The emphasis should be screening should not be initiated if health resources of the treatment and follow-up are not adequate. In that case, you do not screen everyone. You only go for high-risk strategy. Then you have treatment options in which your aim is to obtain a blood pressure below 140/90 and ideally a blood pressure of 120/80. You need to control hypertension in order to reduce the incidence of stroke and other complications. It's a major reason for identifying and treating asymptomatic hypertension. And the care of hypertensives should also involve attention to other risk factors like smoking, elevated blood pressure, and cholesterols. Now, patient compliance. This is very important. The extent to which the patient adheres to the treatment in terms of taking medication, following the diets, or executing other lifestyle changes. The compliance rates can be improved through education directed to patients, families, and the community. Now coming towards our next topic, it's ischemic heart disease and its prevention. By the way, most of these slides have been taken from your textbook, Park and Ilyas Ansari, the authors, and from WHO websites. So ischemic heart disease, the synonym is coronary artery disease. You can call it coronary heart disease. It's a condition where there is an inadequate supply of blood and oxygen to any portion of the myocardium. And it's an imbalance between the myocardial oxygen supply and the demand. So this ischemic heart disease has been identified as an impairment of the heart function because of inadequate blood flow to the heart compared to its needs. These are, in other words, caused by obstructive changes in the coronary circulation of the to the heart, and it's the cause of 25 to 30% of deaths in most of the industrialized countries. It's also known, according to the WHO, as our modern epidemic. So it's a disease that affects the population, not an unavoidable attribute of aging. So what are the causes? Mainly atherosclerosis of the coronary artery, and the types of ischemic heart disease or the manifestations include angina, which may be stable and unstable, myocardial infarction, heart failure, and arrhythmias. It also may include sudden death. So atherosclerosis can affect any artery in the blood. The heart, the person may experience angina, myocardial infarction, or sudden death. If it affects the brain, it may lead to stroke and transient ischemic attack. And if it involves the limb, it may lead to claudication and critical limb ischemia. So this is a picture of showing a blood vessel where there's atherosclerosis occurs, which leads to narrowing of the blood vessel. So there's a decrease in the oxygen supply. So this also has this more or less the same non-modifiable and modifiable risk factors. We'll go through each one of them. So smoking, the degree of risk of developing CHD is directly related to the number of cigarettes smoked per day, as per research suggests. Filter cigarettes probably are not effective in prevention. They're not protective. There is evidence that the influence of smoking is not only independent of, but also acts synergistically. So it's adding with other risk factors such as hypertension and elevated serum cholesterol. The effects are more than additive. The synergistic, so they increase multiple times. If you're smoking and you have other factors such as hypertension and elevated serum cholesterol, it may lead to an synergistic effect. So this is a figure that has been taken from your textbook PARC. It shows the blood pressures, systolic blood pressures. Okay? So as you, and the y-axis has the probability of myocardial infarction per 1,000 people. So its importance of risk factor combination. So when you have a combination of risk factors, you have a synergistic effect, and you have an increased probability of myocardial infarction. So there's a curve A, for example, and these are the blood pressures. So curve A is the risk in the absence of smoking and elevated serum cholesterol, not much increase. So yeah, you don't see much increase in the probability of myocardial infarction. But when you see the curve B, it increases when your systolic blood pressure is increasing. And curve C is even huge. Risk with elevated serum cholesterol, it's huge with increasing systolic blood pressure, and your risk of developing myocardial infarction would increase this way if there is smoking and elevated serum cholesterol as well. So the risk of death from CHD decreases when you cease smoking. The risk declines adequately, substantially within 1 year of stopping smoking, more gradually thereafter until after 10 to 20 years. It is the same as that of a non-smoker. For those who have had a myocardial infarction, the risk of a fatal recurrence may be reduced by 50% after giving up smoking. So that's huge. So your blood pressure, it's the single most useful test for identifying individuals who have a high risk of developing CHD. Hypertension accelerates the atherosclerotic processes, especially if hyperlipidemia is also present, and contributes importantly to CHD. So in the past, there was emphasis which was on the importance of diastolic blood pressures, and many investigators feel that systolic blood pressure is a better predictor of CHD than the diastolic blood pressure. However, both components are significant risk factors. The risk role of mild hypertension is generally accepted. So as I said earlier, in American Heart Association, the classification suggests systolic or diastolic blood pressure may be increased to have hypertension stage 1 or 2. Okay. So serum cholesterol, there's a triangular relationship between habitual diet, blood cholesterol lipoprotein levels, and CHD, and that these relationships are judged to be causal. So serum cholesterol, when you have a not proper diet, your blood cholesterol lipoprotein levels increase, and so does your CHD risk as well. There is no population in which CHD is common that does not have a relatively high mean level of cholesterol. That means greater than 200 milligram per deciliter in adults. So it's very rare to have people having high blood, having CHD with lower levels of cholesterol. There are cultural differences in serum cholesterol levels between countries. For example, Japan and Finland having the lowest incidence, and Finland having the highest incidence of CHD. We'll see how these factors affect the cultural differences, how they affect. So on the x-axis, you have the serum cholesterol levels, and at y-axis, you have the frequency of CHD. So this is for Japan, for example. It's a huge curve, okay? And then you have east of Finland, which have increased serum cholesterol levels. This shows that the risk of CHD rises steadily with serum cholesterol concentration, and it's a 14 years experience comprising of 7 countries that showed that serum cholesterol concentration is an important risk factor for the incidence of CHD at levels perhaps 220 milligrams per deciliter or more. And this supports the notion of a threshold level. So you need, if you have cholesterol levels higher than this, you have an increased risk of developing CHD. So that there are other risk factors. Diabetes, for example, the risk of CHD is 2 to 3 times higher in diabetics than in non-diabetics. CHD is responsible for 30 to 50% of deaths in diabetics over the age of 40 years. In the industrialized countries, there are genetic factors. People with risk having a genetic history might have an increased risk of developing CHD. Then physical inactivity, in which you have a sedentary lifestyle, which is associated with a greater risk of development of early CHD. There is evidence that regular physical activity increases the concentration of high density lipoprotein, which you know is a good cholesterol, and decreases both body weight and blood pressures, which are beneficial to the cardiovascular health. Then there are certain hormones. The pronounced difference in the mortality rates for CHD between male and female subjects suggests that the underlying factor may have a hormonal basis. So postmenopausal women, so for example, have higher blood pressures. It has been hypothesized that increased estrogen may be the common underlying factor that leads both to atherosclerosis and its complications like CHD, stroke, and peripheral vascular disease. Type A personality, they're more hostile, they're restless, they're more competitive, they have a sense of urgency, they may have higher chances of developing CHD compared to people who do not have type A personality. They may be type B personality. Then you have alcohol, high alcohol intake, which is defined as 75 grams or more per day, is an independent risk factor for CHD, hypertension, and all other cardiovascular diseases. The evidence that moderate alcohol intake, it's unsubstantiated as yet. Oral contraceptives, the women who consume them have higher systolic and diastolic blood pressure. There's a risk of myocardial infarction in women who which seems to be increased by oral contraceptives, and the risk is compounded when you are a cigarette smoker as well. Some others include low dietary fiber, sucrose, and soft water, which have been under debate, and dyspnea on exertion and low vital capacity have also been cited as possible risk factors, but they're not confirmed. What's the prevention? It's again multifactorial. Okay? The primordial prevention, you need to work on social determinants of health in the population, such as your political, your economic, your social factors. principally when there's unplanned urbanization, illiteracy, poverty, and poor working and living conditions. Now there's the UN Sustainable Development Goals. Earlier we had the MDGs, Millennium Development Goals. Now we have the UN Sustainable Goals, Sustainable Development Goals, in which there is an involvement of improvement in cardiovascular health and adequate healthcare financing, universal healthcare, which are important for achieving these goals. So you have good health and well-being. You have decent work and economic growth, for example. You have then you have reduced inequalities. These have spelled objectives for reduction strategies for hypertension and CHDs. So primordial prevention, it involves preventing the emergence and spread of CHD risk factors. They're just risk factors that have not, that should not be there. For example, if you have a habit of consumption of high cholesterol diet, you will see it in your family. So when you reduce that risk factor, this will be a risk factor that will be reduced in your family. Okay, this applies to developing countries in particular. These countries should seek to preserve their traditional eating patterns and lifestyles associated with low levels of CHD risk factors. Since the etiology of CHD is multifactorial, it depends, the approach to prevention should also be multifactorial. The aim should be to change the community as a whole, not the individual subjects living in it. So at the individual level, what do we do? Identification of people who are at high risk. Okay, that's the best strategy. That's the high risk strategy, and strategies to improve adherence to healthy lifestyles and drug therapies are essential and can be implemented at health system, healthcare, and patient levels with the use of education, technology, and personalized approaches. Improving the quality of medical education with a focus on ischemic heart disease prevention for physicians, nurses, allied health workers, and the public is required. Now, population level strategies, where the whole population is taken into account for the prevention of CHDs. This it's only if you have the available resources. So it should focus on tobacco control, promotion of healthy foods, fruits, vegetables, legumes, and nuts, curbing unhealthy foods, saturated fats, cut them, trans fats, cut them, refined carbohydrates, excessive salt, and alcohol, promotion of physical activity in everyday living, and the control of ambient and indoor air pollution, which has also been known to cause, known as an important risk factor of developing CHDs. So there's a population approach, again, where you have the biological normality. You have this strategy it's a mass, because it's again a mass disease, and it's a modern epidemic, and it has again a submerged portion of an iceberg. So the focus should be mainly on the control of underlying risk factors. This approach is based on the principle that small changes in the risk factor in the total populations can achieve the biggest reduction in mortality. Shift towards biological normality. You have dietary changes, okay? And according to the WHO expert committee, there should be a reduction of fat intake to 20 to 30% of total energy intake, consumption of saturated fats that should be limited to less than 10% of total energy intake, a reduction of dietary cholesterol to below 100 milligrams, sorry, per 1000 kilocalories per day, an increase in complex carbohydrate consumption and avoidance of alcohol consumption, reduction of salt intake to 5 grams or daily or less. Smoking, there are no safer cigarettes, as I already mentioned. We need to achieve the goal of a smoke-free society where there should be no smoking zone. A comprehensive health program should be is required, which includes effective information, education activities, legislations, and fiscal measures to cease smoking and smoking cessation programs as well. Again, blood pressures. A reduction of 2 to 3 millimeter mercury in the entire population may shift the levels to biological normality of having lower blood pressures. Physical activity, regular physical activity should be a part of normal daily life. Particularly, it's important to encourage children so that they don't have sedentary lifestyles, which is a risk factor. So you're doing primordial prevention, you're primordially preventing. High risk strategy is identifying only those people who may have a higher risk, for example, because of their genes, because of their previously tested blood pressures. So blood pressure and serum cholesterol levels, they need to be identified. Specific advice is having identified those at high risk. The next step will be to bring them under preventive care and motivate them to take positive actions against all the identified risk factors. Okay. So secondary prevention, once the risk factors are there, the damage has been done, you need to identify these people and intervene earlier. The aim is to prevent the recurrence and progression of CHD. Secondary prevention is a rapidly expanding field with much research in progress. Okay, the principle is the same as those already set out in before sections. So you have cessation of smoking, control of hypertension, diabetes, healthy nutrition, and exercise promotion. The most promising results to date have come from beta blockers, which appear to reduce, because it's prompt treatment as well. Secondary prevention comprises of earlier identification and prompt treatment, which appear to reduce the risk of CHD mortality in patients who have already suffered at least one infarct in order to of 25%. So none of the preventive measures discussed earlier lose their importance, even if the first attack has occurred. For example, cessation of smoking is the single most effective means of intervention currently available in the management of patients after having a heart attack. The risk of fatal infarction of sudden death is reduced to 25 to 50%. Stop smoking, nothing else is worth doing. So for example, if you're using beta blockers and you're not smoking and soft there it's already we have evidence of atherosclerosis vascular disease that are the people who have this are at high risk of developing future cardiovascular events. There are various secondary measures that we can work on. Prevention measures such as smoking, hypertension reduction, hypercholesterolemia. Statin therapy, the target should be having pressure of less than 140/85 millimeter mercury. Aspirin and ACE inhibitors. Beta blockers can also be effective.